Thank you very much. Thank you, Dr. Ashish and my co-panelists and all of us gathered here. It's an honor for me, especially to come and speak here, as I'm an alumni of Baroda Medical College, currently in Jaipur. Uh, so can I have my slides?
These are your slides. These are your.
So till now we were discussing and exhaustively we have seen the physiology of exercise and how can a normal person, how normal people exercise. Now what my job is to, my work here is to see what we can tell to our patients and what our diabetic and cardiometabolic patients will go through, because that becomes a totally different set. Their energy levels are different, their metabolism is different, and they have so many disorders. So when we tell our patients the benefits of exercise, if we say in a layman's word, then we can tell him that if you do your moderate amount of exercise, you're going to benefit in the form of there'll be weight loss, lowering of blood pressure, reducing the risk of cardiovascular disorders, you will improve your cholesterol ratios, you will improve your blood sugar, you will have a better back and joints, your joint pains, backaches will be lower, you will be improving your balance, so less of falls, which is very important, as we just saw just a little time back, we just mentioned. Probably we may reduce our medications also because of the exercise, and improving self-confidence, that is very important, and reduce the risk for fall. But as doctors, there was...
I'll move. You're not able to move it.
As doctors, what we look in when we do the exercise training improves the glycemic control, the body composition, the cardiorespiratory wellness, that is very important, the physical functioning, the prosperity also indirectly. And what is important is that exercise is a very important preventive strategy. It has been found for prevention of diabetes, lifestyle modification is most important, even better than drugs. I'll go to that in the next slide. And there are some psychological benefits. We can come back to the slide. The psychological benefits are very important in the form of reducing the anxiety and depression and improving the sleep quality. These are some problems which our patients have very often, and this is a very important aspect which exercise benefits in these patients. Next, please. So this is a very important DPP trial. Many of us must have heard about this diabetes prevention program outcome study, which was published in Lancet, and there are various other studies which were published in NEJM as well in these periods of 2000-2010. They studied a large number of patients, and they put in this, the next please, they put the patients on 3 arms. The arms were of, one was lifestyle modification, one was placebo, and one was metformin, and was found that the patients have the cumulative incidence of diabetes remain the lowest in the lifestyle group. Now this becomes very important that it was lowest in the lifestyle group, even better than metformin. So for prevention strategies, lifestyle is very important, and we know that, and we do advise, but what we usually see is that the patients usually focus on the dietary advice that we give, and the exercise advice is usually just sideline. ठीक है, हम पैदल घूमते तो हैं, walk पे तो जाते तो हैं, but that doesn't become a really focused, proper thing to be done, and it should be done. Next, please. It becomes very important, as we know that diabetes, we are going to be the diabetes capital, and if we see the coronary artery disease by the end of century, we are going to be the coronary artery disease capital also of the world. So globally, we are going to have very big numbers. Prevention is very important. What happens when we talk about the glucose uptake by the muscle? So we were talking about glucose uptake and physiology of that. What is important to note is that under the resting condition, the skeletal muscle is dependent on insulin to promote the glucose uptake. What happens, the insulin goes and binds to the receptor at the membrane, and then that it triggers a cascade of events of intracellular reactions, and one of them is activating the glucose transporter 4, the GLUT4, which then comes and migrates to the plasma membrane and causes a glucose internalization. So when we talk about the resting condition, it's an insulin dependent process, but when we exercise, it becomes different. There it becomes an insulin independent process. How? That when we exercise, there's alterations in the level of intracellular molecules like ATP and calcium, and they begin to regulate the translocation of the GLUT4 and cause a glucose uptake in the skeletal muscle regardless of insulin. So this becomes important in diabetics, where either we have a deficiency of insulin or we have an insulin resistance where it's not going to act. So here, this is very important. So we have a good amount of, after we do the exercise, after our diabetic patient does the exercise, his muscle glucose uptake will remain high for some time post exercise period. Why? these insulin independent
It
mechanisms.
behaves like an insulin almost.
Yes, so it becomes like that when he is exercising. But this has to be remembered, it remains for a short time. So what we have to do that it has to be regular. So if we exercise thrice a week and we are just happy with that, with a moderate exercise, the level we'll see, then that is probably not going to be sufficient for us. We have to do the adequate complete plan. Contracting muscles leads to elevated glucose uptake, contributes to reduction of hyperglycemia, and regular aerobic training boosts the muscle insulin sensitivity also in these patients. It also improves the insulin related uptake by the liver and the other functions. So what should we do? We should have a combination of endurance exercises with resistance training. Now, only endurance exercises, as they were just mentioning in the past few half an hour we are seeing, only endurance probably is good enough, no doubt. But then if we add a resistance training, that would be a greater benefit. And high intensity interval training may be superior, but then that has to be seen as per the patient. As someone said, we have to be careful about how much our patient will be able to tolerate. Accordingly, we have to give the prescription of the exercise. So as I said, a single bout of exercise, though beneficial, will not be enough, and we have to keep on repeating. Please, next please. So what are the recommendations? So the recommendations are that we should do all three, as we said, the aerobic exercises, which are the endurance exercises, the resistance, in some we will mention that, and the flexibility exercises also. When we talk about flexibility exercises, they mainly involve the improved range of motion around the joints. So what we were talking about as yoga and Tai Chi in the Eastern community, that is more of a flexibility exercises where you're mainly going around the range of motion across a joint, and you're improving the patient's balance, which becomes very important. Now, what do we have the aerobics? The aerobics, the intensity, duration and frequency of exercises as well as some safety measures should be explained to the patient when prescribing a training program. And as we just saw, that aerobics involves repeated continuous movements of large muscle groups like walking, cycling, jogging, swimming. They basically primarily rely on the aerobic energy producing systems, as Dr. Ashish just mentioned, and the resistance strength training exercises are for the weights as well as of the resistance bands. So what should we do? What should we ask our patients to do? They can do these low to moderate intensity exercises, as the recommendation goes. Low to moderate intensity aerobic exercises 2 to 7 days a week, which is at least, this is minimum, you can go higher, 150 minutes in total. This is when we talk about the low to moderate degree. That is walking, simple exercises. Jogging or other high intensity exercises 3 days a week. We want around 90 minutes in a week at least. These are recommended in order to improve glycemic control, facilitate weight management, and reduction of cardiovascular disease. But when we talk about maintenance of weight loss, so many times patients say that they have lost weight, they did a lot of dietary and exercise schedules they had taken from some particular set, and then they lost weight, but now they are regaining weight. So if they want to maintain a weight loss, then we have a much higher exercise pattern would be required, around 7 hours per week, almost 2 to 3 times of what we were saying for the normal individuals, of moderate to vigorous exercise would be required. So that is quite high, which probably people are not able to do, and hence they regain the weight. So just one slide back. For most patients, their activities should be distributed over 3 to 5 days per week with no more than 2 consecutive day offs, no 2 day offs consecutive. It could be in between. And weightlifting, other strength training, 3 days a week, which could be combined with the aerobic training. What about our type 1 diabetic patients? So type 1 diabetic patients become a different set because we are a little worried about 2 things. They are on insulin, so we don't want them to have hypoglycemic, and if they are significantly hyperglycemic, we don't want them to develop DKA, diabetic ketoacidosis. So these 2 things have to be kept in mind. The exercise 20 to 60 minutes, 3 to 4 days per week, 50 to 85% of heart rate reserve. We'll see how that heart rate reserve is calculated. And they may use non-weight bearing, low impact activities if weight bearing activities are contraindicated. So use lighter weights and avoid the Valsalva maneuvers and heavier weight for athletes. Most important for type 1 diabetics is drink lots of fluids. So they should be advised to drink lots of fluid, lot of very good hydration, and they also have to see that if they are going a little on the lower side on blood glucose, take some carbohydrate snack. That is very important, so we don't have hypoglycemia.
We'll have 1 or 2 minutes more.
Yeah. Just
So you
just go
just
through.
let me.
So barriers, these are the barriers. We all know that boring nature, lack of time, physical pain, lack of willpower, lack of self-motivation. All of us go through all these things. I'm sure we all know this very well. But the important physiological concerns with diabetes is that hypoglycemia, as I said. Then if the sugars are very high, avoid advising them, let the sugars come down. If more than 300, let them come down. Peripheral neuropathy, another important thing that we have to be careful, because they may develop ulcers. So if they have some Charcot's foot or something like that, non-weight bearing exercises are preferable. Autonomic neuropathy. If someone has autonomic neuropathy and does a heavy exercise, and if the person feels some discomfort, fatigue, some vague symptoms, ask him to stop it, because we really don't know that he might be having a silent MI. So we have to be careful in these patients, and and of course retinopathy. If the patient has a proliferative retinopathy, he should not do a Valsalva maneuver or something which is going to increase the pressures. So basically, next please, we can go to just a single word about the cardiac rehabilitation. In CAD patients also, it becomes very important to have proper exercise pattern. But CAD patients have a much more decompensated lifestyle, a decompensated heart. So how exercise improve? It decreases the myocardial oxygen demand, it improves the electrical stability. It dilates the coronaries. It may have an increase, the patients develop increased collateral circulations, lowering blood pressure, reducing atherosclerosis, improved lipid profile, and of course a glycemic improvement, along with improved platelet function also by reduction of platelet aggregation. And we can go to the next slide. So the fit factors, as Dr. Ashish has already mentioned this.
Intensity of training.
The intensity of. So how do we look into that? How do we see the patient? Because every time you will see that it's written that 40 to 50% of their heart rate reserve. So how do we calculate that? Next, please. So it's a very simple way. Dr. Ashish also said, like it is heart rate maximum we have to see. It is 220 minus age. So suppose 60 years of age, 220 minus age is 160. So that is the maximum. 160 is the maximum heart rate one would try to achieve. But at resting, he has a heart rate of 80. So the reserve is the maximum heart rate minus the resting. So we saw 160 minus 80. That makes it again 80. So that is the reserve which he has. So if we say a 60% of heart rate reserve, then 60% of 80 would be around 48, 50. Yeah. So 50 plus the heart rate at rest. So if the heart rate at rest is 80, so the person who's exercising 80 plus 50, around 130 with heart rate goal is fair enough. That amounts to a 60% of the heart rate reserve. So that is how you calculate how much a patient can do. So we can go to the next.
This
Strength training we've
covered.
already talked about. Just go back. One important, this is a list where are the contraindications in coronary artery disease patients where we do not want them to develop any problem, are unstable angina if the BP is more than 200, systolic, diastolic more than 100, a sudden drop of blood pressure greater than 20 without any cause, aortic stenosis, seismic illness, heart failure which is symptomatic, third degree heart block, or any other such disease which is probably will be aggravated. Don't let him exercise, and let control the disorder first and then go ahead. So next please. So it doesn't get easier as we keep on going. I find this slide very interesting. As we keep on exercising for a longer time, it doesn't get easier, but one gets stronger. Thank you very much.
So thank you, Dr. Swati, regarding the prescription, exercise prescription. I'll ask Dr. Guha to please, because we have fit patients, we have unfit patients. So tell us something about the unfit people, because all people cannot work, walk, run, because many of these patients will be bedridden or chair bound. So tell us about those people.
Yeah, good evening everybody. I am Dr. Shaibal Guha.
I'll change the slides from here.
Yeah, I'll do
You
it.
can just
I'll start with a disclaimer that I may not be as passionate in practicing exercise as our moderator Dr. Ashish does, and that a difference in BMI shows. But I can assure you I'm equally sincere that in advising exercise to my patients, and obviously we don't practice what we preach all the time. So this is the concept of fuel usage in individuals who are fit versus unfit. Being fit means that the individual has a well-developed cardiovascular system, and we all know anything can be done, all the exercise can be trained, and the patient can be trained for it. Fit people have muscle cells that are well perfused with capillaries, a large number of mitochondria. Mitochondria have a high activity, and to generate ATP in the mitochondria, a steady supply of fuel and oxygen and a decent activity of the enzymes and carriers are needed. And if any of these components are lacking, the rate at which ATP can be produced by mitochondria is compromised to some extent. And under these circumstances, the production of ATP by aerobic means that again not sufficient, and result is anaerobic ATP generation, which Dr. Manish had initially discussed. Unfit. Now, who are these unfit subsets? We can classify them into different types. First are the physically unfit, that is a person with a handicap, physical handicap either of the upper limbs, lower limbs, or who has undergone some amputation, or who has been paralyzed in the past, post CVA or post trauma. So those spinal injury patients, those patients, then he can be mentally unfit, a person who is mentally challenged, low IQ patients, birth defects. Those patients, it's very difficult to train him for doing any exercise. So that is a big challenge in that patient. Then again, post-stroke patients who have been mentally obtunded after the CVA, it's difficult to train him and explain to him about the intricacies of exercise. Then somebody who is medically unfit, like post-surgery patients, he can't be obviously do exercise like a normal patient. A post-MI patient who has just recovered from MI, recovered from a serious infection, illness, recovered from ICU, been discharged from ICU recently, those sort of patients, they are medically unfit, they can't do all the exercises we do, a normal person can do. And then very importantly, socially unfit, a person who has been disfigured, accident disfigurement, acid burns, those patients can't exercise like a normal in a gym or on the roads. So that is another special subset in whom we have to train that patient according to his or her capacities of exercise. So what are the basic challenges of exercise in these patients who are unfit? Challenge obviously is, in most of the patients, the challenge is poor muscle mass or poor muscle strength, because we know they have not been, they are not able to exercise as regularly or as long as a normal individual. So obviously the muscle mass would be less, muscle would be weaker. Then endurance and stamina would be less in that category of patients, because again for the obvious reasons. In the elderly subset or in the patients like post-CV or post-patients, instability is a big issue, instability of gait, instability of posture. So we may not treat all the exercises or yoga postures which we have just discussed over the last couple of minutes. Then poor comprehension in another important thing, as I said, mentally obtunded patients, low IQ patients, post-injury patients who have poor comprehension. It's difficult to train them for exercise. And then lack of family support or lack of peer support is another issue in these days of this nuclear family, where a patient who is injured or recovering from an exercise, his children are staying away, his siblings are not there. So lack of family and lack of peer support is a big issue. So what are the type of exercises possible in these patients? Obviously, all the types of exercise which a normal person can do can also be trained in this category of patients. That is the baseline, with some little restrictions, with some special precautions. That's the baseline. So conventional aerobic exercise, like a normal person where he can do a brisk walking, maybe these subset of patients cannot do that. So they can be trained to walk at a slower pace, but gradually the duration can be increased, and that gradual increase in duration should also be slightly slower than a normal individual. Then similarly, jogging may be not possible by most of these patients. Swimming, again, it can be trained to a patient, even these sort of a patient who is physically handicapped or others, special trainer can train him to swim and can train him to float first and train him to do just front stroke or those sort of exercises which impetus on small, slow limb movements. Then cycling at a slow pace for a smaller duration, that is also very helpful. Then conventional isometric exercises like weights, we can start with a very less amount of weight in these patients and for a smaller duration. small amount of little bit of yoga, not the ones we are doing training in a normal patient, but some which involves lesser amount of movement, lesser amount of flexibility. That can be done. Breathing exercises, simple breath holding exercises for 4 5 for tell him to count 10, take deep inhalation, count till 10 and then release it slowly. Releasing slowly is very important. So we can treat him basic breathing exercises like pranayam. That can be done even by a handicapped person sitting on a chair. That is easy. Balance exercises, simple balance exercises. I think Dr. Would be able to, Dr. Janki would be able to say more about it. But simple balancing exercises in these sort of patients, simple tandem walk or standing on one foot for few seconds even. And if they can practice that for long, that also helps a lot in their ability to improve their functions. And exercise duration is almost the same, but again, as I said, we need to go slow and increase the duration on over a longer period of time as compared to a normal individual. And benefits of exercise in this subset is also the same as what we have seen with the other groups. The benefits are same. So these are some of the slides I think Dr. Ashish discussed from the Fit India
Now,
movement.
basically, I am of course an unfit person
you.
has the same capacity as a fit person. The degree of the type of exercises can be changed, but that doesn't mean an unfit person should not exercise. The unfit person should also exercise. The amount recommended is also the same as a fit person, 150 minutes a week. So, what are the conclusions? And these are conclusions from the Fit India movement. So, these are the conclusions. All patients, all adolescents, which our children nowadays should be exercising at least 60 minutes a day, vigorous exercise for all children, and they should have strength at least 3 days a week. These are the recommendations by the Government of India, Ministry of Health, and they should always, these are the recommendations for adults, 150 to 300 minutes a week, so maybe that comes to 30 minutes to 1 hour a day for this for endurance. And or if you are doing super vigorous exercises, then the amount can be less. And at least 2 days of muscle training a day. 2 days of muscle training, this is for all patients. All normal persons also, not patients I would say. And again, as you grow old, your exercise remains the same. So you can say people more than 65 don't mean that they have to exercise less. In fact, they have to exercise more importantly. The type of exercises can be changed. And again, they should have muscle strength exercises, and important that they should have multi-component. So Janki, Dr. Janki, can you tell us something about multi-component exercises? What are multi-component? Which because many of the people of old age, more than 65, or patients who are likely to have frequent falls as they grow older. Can you tell us something about multi-component exercises? So again, there is no difference in the amount of exercises for the older people. This recommended all the patients who are should limit their sedentary time. There are recommendations even for pregnant people. If you can persons, you can see females 150 minutes a week. So there is no restriction for pregnant females also. And those pregnant females who have been doing exercises should be continuing to those exercises during the pregnancy. And we have a criteria both for fit or people with chronic conditions, as Dr. Swati has already mentioned, again 150 to 300 minutes per week. So there is no restriction. No one can tell he's sick and he cannot do exercises. Each and every person can exercise within his or own limits. So I think that should be the conclusion. We should all be exercising and advising our patients to exercise at least 150 minutes a week of endurance exercises, at least two times a week of strength exercises, at least 2 to 3 times a week of stability and flexibility exercises. If you want to go into details, we have a whole recommendations from the Government of India regarding yoga to be done at what age group, which yoga to be done, for how much time to be done, if you can have the interest, you can go through this slide of yoga protocol between the age of 18 to 35. 15 minutes, the amount of yoga. This Tadasana is the palm tree pose, this is the straight leg. So these are all easy postures for 18 to 35. This is the age group from 35 to 50. Again 15 minutes only. Yoga, the main advantage of yoga being it combines strength, balance, flexibility, endurance all into one. So because if you do a plank pose, you are doing strength. So you doing a Surya Namaskar, it in fact combines everything. You can do 50 Surya Namakars, you are doing endurance, you are doing lot of flexibility, you are doing lot of balance, and you are doing lot of strength also. So yoga is a combination of everything. So if you are able to train yourself into a proper yoga and follow these guidelines, you have covered almost all the exercises which are possible. I think that takes care of us. Thank you. Do you have questions? Of yoga? Okay. You can have questions, please. Please, Dr. Imanshu.
If anybody wants to, I would like to ask about high altitude exercise. Those who are going on high altitude, what should be the permitted level of SP?
For exercising or
Trekking, high altitude trekking.
I won't be the. I think I broke. I won't be the proper person to tell this. I have not of high altitude. You should have slow movement. That's the only thing. You should not go on to high altitude over a period of one day. You should take 2 days, then break, then again 2 days break, rather than diving climbing to 14,000. But those specific exercises, you should have endurance. You should have endurance limited, because when you are go for a trekking, you are asked to run for 30 minutes or walk for 60 minutes before the trekking person takes you up for high altitude. So should have a physical fitness.
I would ask Dr. Janki, what about that negative pressure training done for high altitude?
You can train on, suppose you can use assault bikes. Assault bikes are basically cycling, wherein you have to train your aerobic and anaerobic both. Secondly, you can include bridge training. So when you go for a run or outside road run or anything, you can include bridge into that. So that will also help you in inclination and declination. So that also helps, and that you can include in training while you want to go for a trek or anything.
So bridge training and assault bike. These are two
bikes,
recommendations.
Yes, that works
Thank you.
really well.
Yes, Dr. Anupama. Any? Usually the walking becomes the most easiest form of exercise available. You can ask them to do brisk walking, wearing proper shoes in a proper setup, and should not be able to talk on phone while walking. So they can able to, let's think, 45 minutes of walking, and taking the speed should be you are not able to speak long sentences. Speak only four word sentences. You start off with this 45 minutes a day. That's the easiest form. A person who is not born into athletic activity, walking, if they are not able to speak more than 4, remains a reasonably good exercise. His heart rate will go to 120, and that is a fat burning tool. That should be good enough. The second thing you can do is task that is walking.
So what do we mean by sedentary? We mean that it's a low intensity. Yeah.
We have
so
a
low
good amount of people walking. The only problem is that people walk slowly. We should
low
advise
intensity-
brisk walking.
So
I'm not
low
talking-
intensity
not-
done for lesser than 3 times a week is sedentary. I think many of us are sedentary. So you are absolutely right. So a low
This is only the
intensity.
cause why we are sitting over here. Suppose you just think each and every person in this hall just wishes that if this exercise could be packed in a pill, something like that. Each and every person will take and
Doctor,
But the pill does not prevent the disease. It's the exercise which prevents.
Because we all what
No, it has to be done.
okay,
It
but
has to be
Dr.
done.
Anupam, this has to be done.
It has to
You
be
have
done.
to tell.
It has to be done.
I think this
No, I'm not asking you to
go
become.
on and on.
This lecture is being given by me. That's a different thing. But I don't want you to become like me.
I think I just mentioned. I think we just
Two
I
more.
just
Yes.
just one small observation, which I think I missed discussing the recent concept of soleus push-up. That has also come up, and that's a very easy thing and simple thing which we
Anupama,
can
for
advise
you.
our patients, even our sedentary patients, even our handicapped patients. Simple push-up of your soleus muscle when sitting. That activates the soleus muscle, and soleus muscle is unique as compared to other muscles. That about 88% of them are slow oxidative muscle fibers, which use primarily ketone and glucose. So they don't get fatigued if you use it slowly. Soleus push-ups, it has been seen in the trials done at the rate of about 1 per second or 50 to 60 per hour, even while sitting. Yeah. Right. Right.
Yes,
Right.
actually
Yeah. It also helps prevent DVT and it burns calories as well.
we are going to undertake a clinical randomized clinical trial on soleus push-up. The only lacuna is that the literature mentions 270 minutes per day of soleus push-up, which is absolutely impossible. And at the rate of one, so we have cut it down to 1 hour in the morning, 1 hour in the evening. Let us see what comes out of it. We are just going to commence this clinical trial.
Even that would help. Anything would be good.
To yourself 45 minutes, devote time to your body. I will just give that advice to all of my these NCD patients.
Dr.
Other
John,
than your normal life, it's that part. You devote time to your body for 45 minutes.
Exactly. 1 hour to yourself,
one last,
23
one
hours to
last
your
from
profession.
Dr. Komal, please.
Good evening. I take opportunity, Dr. Akashi Satsriya and Dr. also agree. Being a nutritionist, as you were saying that everything was on the website, just for the sake of audience, even the FSSAI Eat Right movement has given all pink book, yellow book and purple book, which is on site, gives details of all the type of food which should be consumed with different type of exercises. Plus, here I would like to emphasize for the children which you have mentioned, because generally people who are not aware of this thing, they feel that all children go for pavilion or go for gym, they are eligible to eat anything. They can have fast food a day or maybe a week because they are doing lot of exercise. So this concept and understanding is very wrong. Please do make them understand when they come to your clinics that it's wrong. They have to do a specific exercise with specific type of food. Thank you.
Thank you.
Agreed. Thank you very much.